Welcome to this explainer. Let's jump straight into our virtual clinical ward walkthrough. We're going to break down some complex soft tissue and neck masses using direct, case-based diagnostics. By the end of this, you'll have a rock-solid framework for spotting these pathologies simply by reading the clinical clues they leave behind.
Here's our roadmap for today. We'll be hitting 5 key areas: benign subcutaneous masses, congenital neck swellings, infectious lesions, diagnostic principles, and finally, dermoid cysts. Let's get right into it.
Section 1. Benign subcutaneous masses. Let's look at some superficial presentations.
All right, consider these two distinct presentations. Case 1 is a 20-year-old with an isolated, painless, pseudo-fluctuant mass right on the chest wall. Case 2, a 30-year-old presenting with multiple, widespread, mobile nodules that show that classic slip sign under your fingers, along with a totally intact skin pinch test. So what exactly are we looking at here?
Notice the stark contrast between these two? That single chest wall mass is a standard subcutaneous lipoma, literally the most common benign soft tissue tumor we see. Interestingly, if you use a deep torchlight, it can actually transilluminate and mimic a cyst. On the flip side, we have lipomatosis, which gives us those multiple slipping masses. And you've really got to watch out for the rare variant, Derkham's disease, also known as adiposis dolorosa. This is where highly vascular lipomas become exquisitely painful, often showing up in postmenopausal women.
Moving on to Section 2, congenital neck swellings. Time for some pediatric presentations.
Okay, picture this. An infant is brought in with a midline dorsal swelling right at the nape of the neck. Now, the absolutely crucial detail in this vignette is that specific location, combined with the complete absence of any lower extremity paralysis or neurological deficits. So what's the probable diagnosis here?
If you guessed meningocele, you hit the nail on the head. A meningocele is a herniation through a posterior vertebral arch defect, but it only involves the fluid-filled meninges. Because there's no raw neural tissue trapped inside, the neurologic prognosis is actually really good. You have to contrast that with a meningomyocele, which does entrap neural elements and characteristically presents with lower extremity flaccid paralysis and incontinence. Huge difference, right?
Let's look at another pediatric case. Here we have a child with a massive 5 by 4 centimeter fluctuant swelling in the classic posterior triangle location. Crucially, it is brilliantly transilluminant. We need to figure out two things. What is it, and what's the gold standard first-line treatment?
This is a textbook cystic hygroma, or lymphangioma. Because it's filled with clear lymphatic fluid inside thin-walled spaces, it glows beautifully under a torch. That finding alone instantly separates it from solid neck masses. Now, complete surgical excision is the gold standard here to protect the airway. Simple aspiration doesn't work. The fluid just comes right back. And complete clearance is notoriously challenging, because these spaces track super deeply along critical neurovascular structures.
All right, shifting to a young adult patient. An 18-year-old male presents with a hard, dull, lateral neck mass right along the sternocleidomastoid muscle. You do an aspiration and boom, the syringe fills with a golden yellow fluid packed with cholesterol crystals. What does this very distinct fluid tell us? Well, that shimmering fluid packed with cholesterol crystals and desquamated epithelial cells is a dead giveaway. We are looking at a branchial cleft cyst. These typically show up in young adults, usually between 15 and 25 years old, and they derive from remnants of the second branchial cleft. As for definitive treatment, you guessed it, complete surgical excision.
Section 3. Infectious lesions. Let's dive into inflammatory processes.
You've really got to pay close attention to the systemic symptoms on this one. A 12-year-old boy comes in with a minimally tender mass on the anterior border of the sternocleidomastoid. But notice the constitutional features. He's got malaise, and very specifically, a low-grade evening fever. What's the most likely pathology? This is a classic cold abscess secondary to tuberculous cervical lymphadenitis. A tubercular cold abscess is driven by liquefactive necrosis, meaning it completely lacks the classic heat, redness, and severe pain you'd see with a typical pyogenic bacterial infection. If left untreated, these sneakily track through the deep cervical fascia to form a pathognomonic collar stud abscess shape before eventually rupturing. Now here is a really debilitating presentation. A middle-aged, obese female presents with recurrent, highly painful nodules in her groin. There are sinus tracts, active purulent discharge, and she has a history of facial acne spots. This specific combo in this anatomical region means we need to look way beyond a simple, localized infection. Any thoughts?
This is hidradenitis suppurativa. Fundamentally, it's a severe disorder of the apocrine gland-bearing skin. Secondary bacterial invaders, like Staphylococcus aureus, are what drives that purulent discharge. And because it's heavily influenced by metabolic factors like obesity, management absolutely mandates aggressive weight loss. For the really severe refractory cases with sinus tracts, we have to do a wide, radical excision of all the affected tissue.
Moving right along to Section 4, Diagnostic Principles and How We Secure Biopsies.
Look at the stark contrast between these next two patients. Patient A has a small, superficial chest swelling. But patient B, they have a massive 6 by 6 centimeter mass on the anterior thigh that's been growing over 10 months and is fixed deeply to the underlying muscle. That huge difference in size and depth completely dictates our algorithmic approach here.
So for patient A's superficial mass, step 1 is fine needle aspiration cytology, or FNAC. It's a fantastic, rapid screening tool that prevents us from creating a contaminated tissue tract. But look at patient B. Listen, any extremity soft tissue mass larger than 5 centimeters that is deep or fixed carries a major risk of being a malignant sarcoma. We have to perform a very careful incisional biopsy, and crucially, we must use pure longitudinal incisions along the limb's axis. If we don't, we risk contaminating lateral tissue compartments, which is bad news for future limb salvage surgery.
And finally, Section 5, dermoid cysts and their cellular variations. Here we have two seemingly totally unrelated patients. Case 1 is a 20-year-old with a soft swelling over the lateral eyebrow that's been there since literally day 1, since birth. Case 2 is a middle-aged tailor who comes in with an exceptionally tense, soft swelling right on the tip of his right index finger. What's the connection?
While even though they look entirely different, they're actually both dermoid cysts. The eyebrow mass is an external angular dermoid. That's a congenital cyst formed when ectodermal elements get trapped along embryonic fusion lines. The tailor's finger, on the other hand, is an acquired implantation dermoid. This happens when a tiny fragment of living epidermis is forcefully driven into deep tissues by occupational microtrauma, like, say, chronic needle pricks over years of sewing.
Clinically speaking, both of these are lined by true stratified squamous epithelium and packed tight with opaque sebaceous material. Because they don't contain clear fluid, there is no way they will transilluminate, which distinctly separates them from other cysts. Plus, unlike your typical sebaceous cysts, dermoids are entirely free from the overlying skin layers. That means there's no central punctum, and the skin just glides easily right over them.
So as we wrap up this explainer, remember that every single soft tissue mass tells a completely unique structural story. A mass isn't just a random lump. Its physical properties, whether it transilluminates, shows the slip sign, or hits that crucial 5 centimeter depth threshold, hold the entire history of how it was created, from embryonic fusion lines to hidden microscopic trauma. The next time you encounter a clinical presentation, ask yourself, are you reading the correct chapter? Keep questioning the underlying anatomy, keep observing closely, and you won't miss a thing.